Welcome to this video on Enlicitide decanoate, known as Lipfendra. This material was prepared by Perry Barton Dakal, PharmD, MBA. In this video, we will explore the role of PCSK9 in lipid metabolism, differentiate Enlicitide decanoate from existing therapies, discuss the pharmacokinetics of this oral peptide, review the coral reef trial results, and examine the clinical position of Lipfendra. Our roadmap today is divided into two main sections: foundational science, which covers lipid biology and the mechanism of action, and clinical evidence, which explores the trial data and regulatory status of the therapy. We begin with Section A refresher on lipid biology and atherosclerosis. Lipoproteins facilitate lipid transport. Key particles include VLDL, HDL, and LDL, which is the primary atherogenic carrier. Apolipoprotein B measures particle number, while lipoprotein A serves as an independent, genetically determined risk factor. The LDL receptor pathway is vital for clearing cholesterol. LDL particles bind to receptors on hepatocytes and are internalized. The receptor then recycles to the surface. PCSK9 interferes with this process, reducing available receptors and raising plasma LDL-C. LDL-C is causally linked to atherosclerosis. Particles infiltrate the arterial wall, leading to plaque formation. This established causal relationship forms the core pharmacological rationale for the LDL-lowering therapies discussed in this video. Statins inhibit HMG-CoA reductase, reducing cholesterol synthesis and upregulating LDL receptor expression. While effective, they have limitations, including a compensatory increase in PCSK9 levels that can partially offset their benefits. Despite high-intensity statin therapy, many patients do not reach their LDL-C targets. The compensatory rise in PCSK9, triggered by statins themselves, highlights the significant residual risk and the clinical need for potent add-on therapies. Common non-statin options include ezetimibe and bempedoic acid. While useful, they often fall short of the LDL-C lowering capacity of PCSK9 inhibition, setting the stage for more advanced oral therapeutic options. We now move to Section B, focusing on PCSK9 biology and the rationale for its inhibition. The PCSK9 gene was identified in 2003. Genetic studies showed that loss-of-function variants lead to low LDL-C and reduced cardiovascular risk, providing the essential proof of concept for the development of PCSK9 inhibitors. PCSK9 binds to the LDL receptor and promotes its degradation in the lysosome. By blocking PCSK9, we prevent this degradation, allowing the receptor to recycle back to the cell surface and effectively clear more LDL from the plasma. Human genetic variants act as a natural experiment. Loss-of-function variants demonstrate the benefits of reduced PCSK9 activity, whereas gain-of-function variants confirm its central role in driving hypercholesterolemia, validating it as a primary drug target. Combining PCSK9 inhibition with statins is highly logical. Statins increase hepatic PCSK9 expression, which blunts their own effect. Adding a PCSK9 inhibitor removes this break, producing a further additive reduction in LDL-C. Moving on to existing approaches for PCSK9 inhibition. Current methods include injectable monoclonal antibodies like evolocumab and alirocumab, and siRNA therapies like inclisiran. Lipfendra, an oral macrocyclic peptide, represents a new class of therapy designed for daily oral administration. This video will now detail the drug profile of Enlicitide decanoate, the active ingredient in Lipfendra. Enlicitide decanoate, branded as Lipfendra, is the first oral PCSK9 inhibitor approved by the US FDA. Developed by Merck, it is categorized as a macrocyclic peptide. Note, do not confuse it with Enflonsia, a different Merck product used for RSV. Macrocyclic peptides offer a middle ground between biologics and small molecules. By cyclizing the peptide backbone, we achieve rigidity, which enhances binding specificity and stability against breakdown, capturing biologic-like potency in a format suitable for an oral pill. Oral delivery of peptides is challenging because these large polar molecules do not easily cross the gut lining. To make Enlicitide effective as a tablet, researchers had to overcome the inherent lack of cell permeability, which would otherwise result in poor absorption. To solve this, Enlicitide is co-formulated with sodium caprate, a permeation enhancer. This compound temporarily loosens the gut's tight junctions, allowing a small fraction of the drug to pass into the bloodstream, where it then provides systemic PCSK9 blockade. Enlicitide acts by binding free PCSK9, physically blocking it from interacting with the LDL receptor. This protection allows the receptors to recycle and continue clearing LDL-C, matching the clinical effect of injectable antibodies but delivered orally. Both Enlicitide and monoclonal antibody inhibitors target the same biological pathway. The fundamental differences lie in the route of administration, the dosing frequency, and individual patient preferences for daily pills versus infrequent injections. A brief teaching aside, be careful not to confuse Lipfendra with Enflonsia. Enflonsia is an RSV antibody for infants, while Lipfendra is an oral cholesterol-lowering medication for adults. Always verify medications by generic name and mechanism. We now transition to Section D, the pharmacokinetics of Enlicitide. The oral bioavailability of Enlicitide is approximately 1%. Despite this low percentage, the drug is so potent that this small absorbed fraction is enough to provide strong daily PCSK9 inhibition. It reaches peak concentration quickly and steady state in about 1 week. Timing is important for absorption. Lipfendra should be taken on an empty stomach in the morning, at least 30 minutes before food. Consuming food too close to dosing can reduce drug exposure by nearly half, as the interaction affects the permeation enhancer mechanism. Enlicitide demonstrates non-linear pharmacokinetics. As dose increases, the body clears the drug faster because PCSK9 target binding sites become saturated. Consequently, plasma levels do not rise in strict proportion to the dose administered. The drug is minimally metabolized and has an effective half-life of about 14 hours at the 20 mg dose. This duration is sufficient to maintain steady-state PCSK9 suppression throughout the day, supporting the once-daily dosing regimen. Finally, Enlicitide has a low burden for drug-drug interactions. This is a significant clinical advantage for the patient population, who are often managing multiple comorbidities and complex medication regimens. We now move to Section E, pharmacodynamics and dosing. This section outlines how Enlicitide functions to lower cholesterol and provides key administrative guidelines. Clinical studies show that Enlicitide reduces free plasma PCSK9 by over 90%. Doses of 35 mg or higher provide sustained suppression for more than 24 hours. This near-complete, sustained suppression of PCSK9 is the pharmacodynamic driver for the significant LDL cholesterol reductions observed in the Coral Reef trials. The approved dosage is one 20 mg tablet taken orally, once daily. It must be taken in the morning on an empty stomach with water, black coffee, or plain tea. Wait at least 30 minutes before eating or drinking anything else, and always swallow the tablet whole without crushing or chewing. Counseling patients is vital. If a dose is missed, take it as soon as remembered, while still observing the 30-minute fasting requirement. Emphasize that adherence to timing is critical for consistent drug exposure. Finally, remind patients that Lipfendra is an adjunct to, not a replacement for, healthy lifestyle habits. We move to Section F, the clinical development program for Enlicitide, known as the Coral Reef Program. The Coral Reef Program is comprehensive, involving over 19,000 participants. It includes 3 pivotal Phase 3 trials focusing on lipid efficacy, familial hypercholesterolemia, and add-on therapy, alongside an ongoing, large-scale cardiovascular outcomes trial involving over 14,500 patients. The trial portfolio is designed to evaluate Enlicitide across the entire spectrum of hypercholesterolemia. These trials are registered on clinicaltrials.gov to ensure transparency and scientific rigor. Coral Reef Lipids was a Phase 3 study in over 2,900 adults with either atherosclerotic disease or high risk for a first event. Patients remained on stable lipid-lowering therapy and were randomized 2-to-1 to either 20 mg of Enlicitide or a placebo for 52 weeks. In the Coral Reef Lipids trial, Enlicitide demonstrated a significant placebo-adjusted LDL cholesterol reduction of 55.8% at week 24. These findings confirm the potent efficacy of the drug in real-world clinical conditions. The Coral Reef HeFH trial evaluated the drug specifically in patients with heterozygous familial hypercholesterolemia. This study randomized 303 adults to either Enlicitide or placebo to assess both efficacy in lowering LDL-C and safety over a 52-week duration. The HeFH trial results showed a placebo-adjusted LDL cholesterol reduction of 59.4%. This provides the first Phase 3 evidence of antibody-like LDL reduction from an oral PCSK9 inhibitor in a genetic hypercholesterolemia population. Coral Reef add-on compared Enlicitide head-to-head against other common non-statin therapies like ezetimibe and bempedoic acid. This study involved over 300 patients to determine the comparative efficacy of adding Enlicitide to existing statin regimens. At the ACC.26 conference, data confirmed that Enlicitide outperformed the other studied oral add-on agents, demonstrating superior LDL-lowering efficacy in statin-treated patients. Across the entire program, Enlicitide showed consistent benefits beyond just LDL-C, including meaningful reductions in non-HDL cholesterol, ApoB, and lipoprotein A. Post-hoc analyses also indicated a safety profile comparable to placebo. Finally, the Coral Reef Outcomes trial is ongoing. Its goal is to confirm whether Enlicitide-induced LDL lowering reduces major adverse cardiovascular events like heart attacks and strokes. This is the final step in establishing its full clinical utility for high-risk patients.